Hey guys, how are you all? Welcome back to MedSteps YouTube channel. So today in this video we are discussing about very high yield topic and most commonly we can see in pediatric trauma. Okay, so this is high yield emergency topic, that is supracondylar fracture of the humerus. Okay, so in this video we are discussing about little amount of anatomy and pathophysiology and mechanism of injury and complications and management in surgical management and how we can do the treatment and everything we can step by step we are going to discuss. Okay, so first one, supracondylar fracture of the humerus. Before that we have to understand this fracture is happening in humerus. In this humerus also in exactly in distal area of the humerus. In distal humerus we can see some coming out, some bulging out parts. That part we call if it's in medial, then we call that is medial epicondyle. If it's in lateral, this we call then that was lateral epicondyle. Okay, so here if any fracture happening in this condyle region, then we have to think that is supracondylar fracture. Okay, this fracture of the distal humerus just above the epicondyles. That means mostly that fracture happens in this superior part, that means above the epicondyles. Okay, that's why we call supra means up, that means superior of the condylar. Okay, so that's why that name came supracondylar fracture of the humerus. It's mostly occurring in children like age 5 to 7 years old. Okay, so why we have to take tension about this fracture means it's high clinical relevance we have, that is neurovascular compromise, and it can cause risk of compartment syndrome and it can cause the growth disturbance also. Okay, so that's why we have this is very emergencycal orthopedic condition. Okay, how this fracture will happen? This common cause is fall on an outstretched hand. If any child is fall on an outstretched hand, then that because of with this elbow extension, that child will get this supracondylar fracture. Okay, so I already mentioned vascular compromise will be very close, some arteries and veins and nerves will pass from this condylar region. So that's why we can see some brachial artery injury and distal pulse, and hand will be in pink. And the supracondylar fracture name is also known as the pulseless hand. Okay, so now we are going to discuss little anatomy. I already mentioned here most of this fracture happens in distal humerus. In distal humerus is mostly composed of medial and lateral epicondyles. In medial this lateral epicondyles we can see. Okay, I will show you some image. This is capitulum. Okay, in this capitulum we can see in lateral, and it articulates with radius. Okay, so capitulum will be we can see in lateral region, lateral part, and it articulates with radius. Next one we can see the trochlear, that means this one. This trochlear we can see in medial part. Okay, so it's presenting these parts will help for it will help for giving support to radius and this humerus and this parts. Okay, so if you are seeing this trochlea, we can see this will be in medial and it articulates with ulna. Okay, with ulna. That means This capitulum will form, it will articulates with radius, that means forming the joint of the radius, and here this trochlea is we can see the medial of the humerus, and this trochlea will articulates with what? Articulates with ulnar bone, ulna. Okay, so this supracondylar region is the very narrowest part of the humerus. So it's structurally weak, and most commonly fractures happen here. Okay, this supracondylar region, this is very most narrowest part of humerus. So structurally it will be very weak, so common fracture site. Okay, now we are going to see the very important part, that is ossification centers. Ossification centers. In this ossification centers, we have to focus on ossification centers means appears in a predictable sequence based on age approximity. Okay, so for this thing we have one mnemonic, that is CRITOE. Okay, that is CRITOE. If you are seeing this CRITOE mnemonic, first one C means capitulum. I already mentioned what it will be. Capitulum means, we can see that ossification will be like center will be 1 year, and radial head will be 3 years. Next, internal medial epicondyle will be 5 years. Next one, T means trochlea, 7 years. O means olecranon, it will be 9 years. Next, external epicondyle, lateral epicondyle, external or lateral epicondyle, it will be 11 years. Okay, why this? Mostly these ossification centers will help us for it's very useful for interpreting of pediatric elbow in X-ray, pediatric elbow X-ray. Okay, so now we are going to, in anatomy we are going to discuss little amount of neurovascular compromise. We have some neurovascular structures passing from that fracture area. Like first one we can see brachial artery. If you are seeing this brachial artery, yeah, this is brachial artery. Okay, this one brachial artery. That brachial artery we can see anterior to supracondylar region. So this is very risk of tear. If any fracture happened here, then it can that blood vessel will get like tear. Okay, that's why this is very like neurovascular compromise will happen here in, and sometimes we can see because of this brachial artery tear, because of risk of injury, we can see sometimes pulseless hand. Okay, because artery is teared, so that blood flow we can't see, so pulse also we can't feel, so that's why pulseless. Next one, if you are seeing, means we can see median nerve. This is the median nerve. Okay, this median nerve runs with the artery. Okay, if any fracture happen, means with the brachial artery, that median nerve also can get stretched, or it can cause it can get like tear. Okay, so in lateral region, mostly in lateral region we can see radial artery. For example, this is lateral region. In lateral we can see radial artery lateral. Okay, so laterally that radial artery will pass. If any patient getting like lateral fracture, laterally that fracture happens, means that radial artery also can get tear. Next one, ulnar nerve. If you are seeing this image, this ulnar nerve is coming from posterior to medial epicondyle. It's very less involved in this fracture. Okay, so ulnar nerve is like posteriorly we can see that patient will get this like stretching or like tear. Then we can see that that patient can't do flexion of the elbow. Okay, so here in median now the patient can't do the extension of the injury, and the patient can't do the OK sign. Okay, and another thing here, most important thing is in supracondylar fracture, most commonly stretched nerve and tear injury happening of means most commonly injured things means median nerve and brachial artery. It's very important. After doing surgery also, after doing reduction also, after fixing screw and plates and these things also, some people will get because of the traction, because of the tear, patient will get neuropraxia. Neuropraxia means that nerve will work very slowly. That means 50% of nerve only it will work. So that condition we call neuropraxia. This thing happens because of traction. Okay, so this is the neurovascular thing. I will write here like normally. Brachial artery. Next one we discussed about median artery, median nerve. Next one radial nerve. Next one ulnar nerve. So in brachial artery we can see it will pass anterior to supracondylar region. Risk of injury. Next one in median nerve, it runs with the artery. Radial nerve mostly we can see laterally. Ulnar nerve posterior to medial. Medial epicondyle. It's less involved in the fracture. So guys, if any fracture happen in lateral epicondyle, then we have to think about radial nerve injury. If posterior means ulnar nerve injury. If normal like anterior part of the fracture means, then we have to think brachial artery and median nerve. Okay, so next classification. We have one classification, that thing we call the Gutland system. For this fracture, this classification is mostly in extension type of fractures. Okay, if you are seeing this image type 1, here you can see some non-displaced, that means that fracture is there but undisplaced. Okay, so this will comes in type 1 Gutland extension type of fractures. The second one type 2. In type 2 we can see some displaced here, some displaced and with intact posterior cortex. Okay, so it's like displaced with intact posterior cortex of the humerus distal part. Okay, next one type 3. In type 3 we can see that fracture happen, and most commonly we can see this fracture like completely displaced and no cortical contact. Okay, so most commonly we can see like we have to do, this is very emergency condition, because if you are not like take caring of this fracture, you are not doing immobilization, you are not doing any reduction, then greater than 6 hours means that patient can get compartment syndrome. So that's why we have to, this is type 3 is very like severe condition. Okay, so when it's coming to type 4, it's like very mostly multi-directional instability or periosteal disruption. So here this is from multidirectional, that external force stress came, so that's why we can see multidirectional instability, or it's like complete periosteal and disruption. So when in X-ray we can easily find out this type of type 1, type 2, type 3, type 4 fractures. Okay, next one, mechanism of injury. If any patient got, mostly this is like extension type fracture. Here in extension type of fracture, like 95% of patients we can see fall on an outstretched hand. Okay, and some posterior displacement of the distal fragments also we can see here. Next one, flexion type. In flexion type we can see that that patient fall on flexed elbow, and anterior displacement you can see in this patient. Okay, so here what are the clinical features we can see in this patient? Means first one, pain and swelling and like deformity at elbow. Okay, and S-shaped deformity and limited or absent movements, and we can see some neurovascular compromise signs like absence of radial pulse, so pulselessness is like related to vascular, and weak hand grip or sensory loss because of traction of the nerve, and always we have to perform and document of radial pulse and capillary refilling and neurological exam also. Okay, whenever fracture happening we have to focus on these things. Okay, next one, radiology. In this radiology, first of all, always we have to see the displacement. In displacement, if we are seeing that in X-ray, the X-ray will be like displaced, and we can see some angulation and combination. If we are seeing this first X-ray, here we can see anterior humeral line, that from humerus we have to draw one imaginary line. If beyond that anterior humeral line, then we have to think about type 1 fracture. Okay, next one, if you are seeing this imaginary line, it should pass through the middle of the third of the capitulum. Okay, if it's not passing, means some displacement happened, like that we have to think. Next, in next X-ray, if in humeral area, if any black scale sign or some posterior fat pad sign if you are seeing, means then we have to think it will indicate like joint effusions. Okay, next one, Bowman's angle. We have to make one angle like this. In this Bowman's angle, if patient got like 70 to 75 degrees, means it's normal. If more than 70 to 75 degrees or less than 70 to 75 degrees, means then it's like supracondylar fracture, or some displaced happen, like that we have to think. Okay, next, before going to the management, I have to tell you one thing. We have one triad. The triad we called terrible triad injury. Where I can write this thing. Okay, we have one triad. The triad we called it's mostly happens in elbow. In elbow triad we call the triad terrible triad injury. Here you can see total 3 things. Okay, first one, you can see the radial head fracture, and we can see dislocation of the elbow, and the coronoid fracture. If you are seeing these 3 things, then it will comes to terrible triad injury. Okay, it will not comes in supracondylar fracture, so we don't confuse with these things. Okay, so now we are going to see the management of. If you are seeing this management, if patient is pulseless hand, then what we have to do? If is it well perfused? if that patient hand is well perfused, then we have to do closed reduction and surgery. Okay, so here in closed reduction, or we can use some pinning, and we have to reassess the vascular states. If usually if like we have to observe for patient for like 24 to 48 hours. If after that thing, if the circulation is bad, then we have to take consultant from vascular. Okay, vascular consent we have to take. Next one, pulseless. We can see pulseless and poorly perfused means we have to do emergency surgery for reduction and fixation of the fracture. If the hand continues to be pulseless and poorly perfused after reduction and fixation, then you will need the vascular surgeon. Okay, now if immobilized in elbow flexed at 30 to 40 degrees, if neurovascular compromise, then we have to do the initial stabilization, and we have do not if some cases we have to don't flex fully is in suspected of compartment syndrome. Okay, so in type 1, first of all we have to do immobilization with posterior slab. That means we have to apply some posterior splint and long arm cast, 90 degrees flexion, and we have to do close follow up with weekly like X-ray for 2 to 3 weeks. In type 2, we have to do closed reduction plus percutaneous pinning, like we have to do long arm and we have to apply long arm cast. Some may need K wire. Okay, and we have to avoid hyperflexion greater than 90 degrees if vascular status is uncertain. In type 3, we can see we can do closed reduction plus K wire fixation. Okay, in type 3 and type 4, we can do often need some open reduction, like this is urgent orthopedic intervention, like it's like closed reduction we have to do, and percutaneous pinning. Usually lateral entry may need to medial pin. Okay, in open reduction, if closed reduction fails, then we have to do open reduction and vascular entrapment also. Okay, now in complications, we can see some neurovascular injury. What are the neurovascular injuries we can see here means neurovascular injury, especially median nerve and brachial artery. I already mentioned this thing. Next, we can see sometimes Volkmann's ischemic contracture. If we are missing about the compartment, if we are missing the compartment syndrome, if greater than 6 years, then it can cause Volkmann ischemic contracture. Mostly we can see in elbow. Okay, contracture. Next one, we can see like malunion. Okay, next in these three things will be comes in early complications. Next one, late complications. In late complications, we can see cubitus varus. This cubitus varus we can see in gun stock deformity. Okay, this in cubitus varus we can see like cosmetic deformity usually from malunion. If patient have malunion, then if we are living like that, then it can cause cubitus varus like Genstock deformity or cosmetic deformity, and it will usually because of malunion. Next one, stiffness. Why you are getting stiffness means due to prolonged immobilization. Okay, due to prolonged immobilization, that patient can get stiffness. Okay, next myositis ossificans, and we can see some growth arrest like due to physical injury, or it's very rare, or you can see some deformity. So guys, we discussed here about supracondylar fracture of the humerus. We discussed some introduction and anatomy, then after mechanism of injury, and we have some classifications. The classification we called Gatland extension type of fractures. Total 4 types of fractures we discussed, and we discussed some clinical features, radiology, and how we have to do management, and what are the complications we can see in this patient. So in key points, most common pediatric elbow fracture, if anyone asking means we have to tell supracondylar fracture. If most common nerve injured in supracondylar fracture means anterior interosseous branch of median nerve, and most common artery means brachial artery. Most common complications is cubitus varus, and in red flag we can see like absent radial pulse and cold hand. For the things we have to do urgent ORF. Okay, so everything we discussed, I covered everything. If you have any doubts, you can ask me in comment section. Like, share and subscribe. Take care. Bye bye.